So, good evening. We will be looking at anatomic and physiological changes in pregnancy today in our lecture. And I want it to be as practical as possible because I'm sure we would have handled or anesthetized a pregnant woman before. So, I would like to start with this question. A 25-year-old primigravida woman is scheduled for an elective cesarean session due to macrosomic baby. Answer the following questions. Number one, list the physiological changes of pregnancy that you expect in this patient. Number two, what are the anatomical and physiological changes that will affect your decision to offer her a regional anesthesia? And number three, enumerate your concerns for general anesthesia for this patient. All right, these are some of the things we will try to answer in our lecture. So the question is to just sensitize our mind as to what to expect. There's a second question I want to read to us also. All right, a 32-year-old gravida 6 para 4+1 woman presents with an acute abdomen with suspected acute appendicitis at 28 weeks gestation. She's been prepared for an emergency laparotomy with appendectomy. You have been asked to provide anesthesia for this patient. So question one, enumerate your anesthetic concerns for this patient. Number two, enumerate how you will proceed with your anesthetic plans. All right, so these are questions that I want us to pay attention to as we deal with this topic of anatomical and physiological changes in pregnancy. All right. So let's go to the lecture. If we have time, we may come back to look at some of these questions. Now, the physiological changes or anatomical changes that are observed in pregnancy are due to the metabolic demands of the fetus, the growing fetus, the placenta, and the uterus. And all these are result from the increasing levels of pregnancy hormones, particularly those of progesterone and estrogen. These anatomical changes present unique challenges for the anesthetic management of the pregnant woman. All right. Now, this is just anatomy of pregnancy. As you can see, the growing fetus, all right, nicely, coiled up in the mother's uterus. And you can see the diagrams here. This is just to sensitize us to know that when you are dealing with a pregnant woman, you are dealing with two people. All right, and I like this picture because it's showing us the face of this baby, all right, which was taken from one of my references. So you can see that when anesthetizing a pregnant woman, just remember that you're dealing with the parturient and her unborn child, the fetus. All right, so during the development and growth of the fetus inside the womb, all right, like I showed you earlier on, there are several anatomical changes, all right, that occur, and physiological changes also, that occur in the pregnant mother to accommodate the process, all right? And these changes include the development of the placenta, all right? And we're going to see how important this placenta is as we go on, all right? There's an increase in size of the uterus, all right, to accommodate the growing fetus. And this comes along with abdominal extension, weight gain, breast enlargement or engorgement, and some postural changes. All right, there's softening of the cervix tip at the beginning of the 6th week of pregnancy. The vaginal mucosa also becomes thick and prepares itself for stretching during labor and birth. And more importantly, all the systems of the body are involved in these changes to provide for both maternal and fetal needs and also for the purpurium. Now, but thankfully, all these changes normally will revert to non-pregnancy state after birth and lactation. Now, this is arguable because a lot of women do not return back to their pre-pregnancy state because of so many fat depositions and all the changes that have taken place. All right, so we look at the systems. The first system I want us to look at is the female reproductive system itself. All right, and our concern is the uterus because that's what houses the growing fetus. The uterus undergoes extreme structural and cellular changes. All right, and due to the elevated levels of progesterone, all right, it maintains in passive non-contract state until the time of delivery. And all right, this adds the effect of progesterone as to, aid the growth of placenta and, a lot of vascular remodeling that takes place between the mother and the child through the placenta. Note that estrogen is the hormone that's responsible for initiating the initial growth process of the uterus during early pregnancy. As pregnancy progresses, the uterus increases from just 70 grams to more than one kilogram, with the volume capacity increasing from just 10 mils to 5 liters. All right. At 20 weeks of gestation, the uterus rapidly elongates and the walls begin to thin out. By 28 weeks of gestation, where maximum fetal growth must have occurred, the uterine tissue begins to slow down while it continues to stretch rapidly and become thin. Within several weeks of delivery, the uterus then attempts to return back to its pre-pregnancy structure. So most of the changes in the reproductive system of the female has to do with the uterus and the cervix. All right, cardiovascular system. No, actually, let me start by saying that no system in the pregnant woman is spared from the changes, all right, both anatomical and physiological changes. So let's start with the cardiovascular system. The cardiac output increases geometrically from 30 to 60% during pregnancy. And most of these changes in cardiac output increases during the first trimester. By 20 to 24 weeks, maximum cardiac output must have occurred, and this is maintained until delivery. Note that initially, the increase in cardiac output is as a result of increase in stroke volume. But towards the end of the third trimester, the stroke volume reduces, but an increase in heart rate, all right, helps to maintain the increased cardiac output. In systemic vascular resistance, due to the effect of elevated progesterone, all right, there's drastic reduction in systemic vascular resistance with a concomitant reduction in arterial blood pressure. All right, this is all due to the smooth muscle relaxation effect of progesterone. The systolic blood pressure decreases, all right, approximately to about 5 to 10 millimeters of mercury normally, but the greater decrease occurs with the diastolic blood pressure, which decreases by 10 to 15 millimeters of mercury. Note that this decrease in blood pressure, all right, reaches its lowest point at 24 weeks, all right, at which point it slowly begins to return to the pre-pregnancy levels, especially in normotensive pregnant patients. All right, the pulse rate, there are a lot of changes in the pulse rate. You can have bounding or collapsing pulses, and you may also have ejection systolic murmurs, and these are common things, common physiological changes in pregnancy. Sometimes there may be an added heart sound, and ectopic beats and peripheral edema are also common. ECG changes also occur in pregnancy, and this is due to the different position of the heart during pregnancy. Some of these changes are considered physiologic, all right, and you may have physiological changes in the atrial and ventricular ectopic beats, You may have some small Q waves, inverted T waves, especially in lead 3. You can have ST segment depression, and you may even have two-wave inversion in the inferior and lateral leads. And most of the times you can have a normal left axis shift. These are normal ECG changes that are common in pregnancy. In the respiratory system, all right, there are a lot of changes in the lung volumes, all right, and funny enough, I saw this TLC, and I don't know if many of us remember what TLC means, total lung capacity, but I also like to call it tender loving care. Unfortunately, in pregnancy, there's a 5% reduction in TLC. Those of us who are men, is that true? But for total lung capacity, there's a 5% reduction in total lung capacity. The tidal volume increases. All right, at the end of the day, you have a reduction in your respiratory reserve volume. And don't forget that the mini volume also increases concomitantly with your tidal volume. But most of the time, the respiratory does not change. So the increase in minute ventilation or minute volume is as a result of increase in tidal volume. A lot of changes also occur with the blood gases. All right, due to the increase in minute ventilation or minute volume, there's an increase in alveolar partial pressure of oxygen and arterial partial pressure of oxygen, which also leads to a decrease in alveolar carbon dioxide and arterial carbon dioxide. Now, this decrease, the PaCO2 decreases for a pregnancy level of 440 millimeters of mercury to as low as 30 millimeters of mercury by 20 weeks. All right, and this is due to the increase in minute volume. But another important thing that where this occurs is that this decrease in carbon dioxide as pregnancy increases or progresses is very important because it causes a carbon dioxide gradient between the fetus and the mother, which enhances carbon dioxide removal from the fetus. All right, this is important as we go on, because you know that carbon dioxide will move by diffusion, so it will move from levels of areas of high levels of concentration to a low level. So if the mother has a lower PaCO2, you expect, diffusion of carbon dioxide from the fetus to the mother, and the mother expires the carbon dioxide out. Okay, these changes are needed to accommodate the 15% increase in metabolic rate and 20% increase in oxygen consumption that occurs during pregnancy. So all this makes room for an increase in alveolar PO2, increase in arterial PO2, reduction in alveolar CO2 and arterial CO2, all are geared towards ensuring that the increase in metabolic rate and oxygen demand in pregnancy are well taken care of. There's what we call dyspnea of pregnancy, all right? The decreased PaCO2 levels, the increased tidal volume, and the decreased total lung capacity all combine to result in what we call dyspnea of pregnancy. And this occurs in more than 60 to 70% of pregnant patients. All right, it is a subjective sensation of breathlessness, but with no hypoxia present. So the patient may be breathless, but the PaO2 or the SpO2 remains normal. All right, it is common during the third trimester, but in some patients, it can actually start at any time of the pregnancy stage. Of concern to us is the airway, obviously. All right, there's what they call edema and engorgement of the airway passages, which may lead to difficult airway and increased tendency to bleeding during instrumentation of the airway. All right, remember the question I started with, so you're beginning to get your answers from this presentation. There's nasal obstruction, all right? There's increased, because of increased vascularity, there's increased epistaxis, and most pregnant patients will prefer mouth breathing and may not tolerate nasal cannula. I hope you understand that a lot of times we feel that pregnant women need oxygen supplementation, and we give them oxygen via nasal cannula. Note that most of these women will mouth breathe rather than breathe through their nostrils. In the gastrointestinal system, All right, the elevated levels of estrogen, progesterone, and ACG combine to bring about nausea and vomiting. And this is what we normally call morning sickness. Don't forget also that because of the increased metabolic rate and reduction in blood sugar levels, you can also experience nausea. You know, morning sickness develops in over 70% of pregnancy and can occur at any time of the day. All right. Women that have serious morning sickness can often tell you how discomforting, and even their partners, how discomforting it can be. All right. But thankfully, it resolves by weeks 14 to 16, but some women may persist beyond 20 weeks in about 10 to 20% of pregnant patients. In the GIT, there's what we know as reduction in gastric emptying time. All right, this is prolonged gastric emptying time. All right, this is due to elevated progesterone levels, which cause smooth muscle relaxation. And when this is combined with decreased gastroesophageal sphincter tone and upward displacement of the stomach, most patients, about 30 to 70% of pregnant women will experience reflux, or what we know as heartburn. All right, every pregnant patient is taken as a full stomach, all right, and the reason is because of the progesterone-mediated smooth muscle relaxation, all right, leading to decreased motility in the large bowel, resulting in increased water absorption, all right. There's reduced acid secretion, all right, reduced motility and prolonged gastric emptying time. All of this will lead to increased risk of aspiration from increased gastric residual volume. All right, in the mouth, because of high vascularization, and they're also very less resistant to infection. In the renal system, all right, the activities of renin angiotensin aldosterone system is activated early in pregnancy. All right, with increased production of aldosterone, there's increased sodium reabsorption. But the good thing is that there's also about 50 to 60% increase in renal plasma flow and glomerular filtration rate, which helps to maintain sodium plasma levels. All right, the increase in renal plasma flow and glomerular filtration rate parallels the increases in blood volume and cardiac output. All right, and the drawback there is that this increase in GFR may overwhelm the ability of the renal tubules to reabsorb, all right, some of the solutes, and this may lead to a lot of increases in glucose and protein losses in the urine. So most pregnancies, most women have some degree of mild glycosuria and or mild proteinuria, which can occur in normal pregnancy. All right, additionally, elevated progesterone levels and prostacyclin, all right, and with angiotensin-1 receptor modification pregnancy cause a relative resistance to angiotensin-2, which is a potent vasoconstrictor, all right, and this also helps in causing more vasodilatation globally, especially in the renal system. All right, so there's increased renal vasodilatation. This is due to the effect of progesterone, all right, and leading to reduction in vascular resistance of both the afferent and efferent arteries, all right. This leads to increase in renal blood flow, also leading to increase in the size of the kidney. All right, progesterone has to reduce ureteral tone, peristalsis, and contraction. So all of this leads to dilatation of the ureters. The blood urea nitrogen and creatinine levels also decrease by as much as 25%. All right, the elevated GFR combined with increased glomerular capillary permeability to albumin results in an increase in fractional excretion of protein to as much as 300 milligrams per day. So because there is reduced tubular reabsorption, all right, of blood glucose and urea, you can expect that all of these solutes will, their loss through the kidneys will also increase because of less effective tubular reabsorption. All right, hematological system is not spared. That's what we call dilutional anemia. All right, dilutional anemia resulting from a disproportionate increase in plasma volume, so as high as 45 to 55%, as against 20 to 30% increase in red blood cell volume. All right, so you may have dilutional anemia with reduced HB. All right, this may not be clinically significant, but just for us to know. The white blood cell count increases to as much as 6 to 16 million per mil and can be as high as 20 million per mil during and shortly after labor. All right. The platelet concentration also decreases. This is also due to a disproportionate increase in plasma volume, but most of them clinically they stay within normal limits. All right. Some women, about 5 to 10%, may even have as low as 100 to 150 platelets per micrometer liter without any pathology present. All right. Coagulation factors, fibrinogen factor 7 to 10 tend to increase, but know that the clotting and bleeding times remain unchanged. But because of increased venous stasis and damaged blood vessels, there may be increased rates of thromboembolic events during pregnancy. The increase in the risk of thromboembolic event actually increases in the first trimester, and continues at least 12 weeks postpartum. So even after delivery, up to 12 weeks, the patient is not free from the risk of thromboembolic events. The endocrine system is not spared. There's increased thyroid functions, all right? And this is due to the estrogen-induced stimulation of thyroid binding globulin, which leads to increased levels of tyrosine and triiodothyronine T3 and T4. All right, although their free levels are slightly altered, but remain slightly constant. All right, the thyroid stimulating hormone levels decrease somehow in the first trimester. All right, but they increase again at the end of the first trimester. But note that despite these changes, all right, pregnancy is considered a euthyroid state. Adrenal gland activities, there's increased hormone production by the adrenal glands, all right? And there's, because of the reduced systemic vascular resistance and blood pressure that is stimulated by the renin angiotensin-aldosterone system, there's a threefold increase in aldosterone by the end of the first trimester. And at the end of the third trimester, you have a precipitous increase in tenfold of aldosterone, all right? And also there's increased production of cortisol, adrenocorticotropic hormone, and what have you. All of these result in hypercortisol state. At the end of the third trimester, the total cortisol levels are said to be 3 times higher than in a non-pregnant woman. Okay, by the end of pregnancy, the placenta also contributes to the increased cortisol state due to its production. All right, and all of this help to trigger labor at the end, at term. Estradiol, a variant of estrogen, increases, all right, in pregnancy, and this increase leads to increased serum prolactin levels by as high as tenfold by the end of pregnancy. And the importance of this is that it helps to induce increased production of oxytocin from the posterior pituitary gland, all right? And this level actually increases throughout pregnancy, but peaks at term. And you know the importance of endogenous oxytocin levels. The musculoskeletal system and the dermatological system of the pregnant woman is not spared. All right, there's what we call increased lordosis, loss of posture. All right, and this is due to increase in the center of gravity, which increase in pregnancy. And the increased lordosis that you see predisposes a pregnant woman to frequent low back pain and flexion of the neck. All right, and this shift in posture can make lower back pain more severe as pregnancy increases. All right. Due to the effect of relaxin and progesterone, there's increased mobility and widening of the sacroiliac joints and pubic symphysis. All right, with joint laxity in the lumbar spine. Interestingly, there's increase in carpal tunnel syndrome, which may be due to the compression of the median nerve. Increased estrogen level result in spider angiomata and palmar erythema. Elevated melanocyte stimulating hormones and steroid hormones lead to hyperpigmentation of the face, nipples, perineum, abdominal line, and umbilicus. All right, I mentioned this before. Increased level of relaxin produced by the placenta softens the cervix, preparing for delivery, relaxes the pubic symphysis, and inhibits uterine contractions in preparation for delivery. All right, ligamentous laxity, I mentioned that before, of the spine increases the risk of back pain associated with pregnancy. The central nervous system is not spared, and this has to do with our anesthetics. All right, the minimal alveolar concentration of our drugs decreases progressively by as much as 40% for all your general anesthetic drugs. They only return to about normal on the third day post-delivery. All right, and this is thought to be due to the sedative effects of progesterone and endorphin, which increases during labor. Your minimum local anesthetic concentration also reduces by 10% for epidural LA due to increased sensitivity to local anesthetic agents during pregnancy. All right. It's also due to hormonal influences and engorgement of your epidural venous plexus. And that's why you reduce the concentration and also the dose or the volume of local anesthetic agent that you use during pregnancy. I'm aware that as low as 1.2, 1.5 of bupivacaine, heavy bupivacaine, has been used successfully for CS, all right, in patients, in pregnant patients. When we're talking about metabolism, don't forget that I said there's about 15 to 20% increase in the rate of metabolism. All right, and some of these things are due to the placenta, which produces hormone. All right, actually, placenta is a hormone-producing tissue during pregnancy. It produces hormones like the human placenta lactogen, all right, which helps to supply adequate nutrition to the growing fetus. And what does it do? It induces lipolysis, making free fatty acid preferentially being used by the pregnant mother for fuel. All right, human placenta lactogen is an anti-insulin agent, all right, and this is what is responsible for the diabetogenic state of pregnancy. All right, so this activity prompts hyperplasia pancreatic beta cells to produce more insulin and protein synthesis. All right, but don't forget that there's increased antagonism to insulin levels during pregnancy, and this may be followed by increased resistance to insulin effect in second and third trimester. All right, there's increased synthesis of cholesterol and triglyceride levels by the liver during pregnancy. All right, the LDL cholesterol increases throughout pregnancy with a 50% increase at term. All right, HDL cholesterol increases during the first half of pregnancy, but falls during the third trimester and may stay a little above the non-pregnant levels. All right, don't forget, like what we said about the placenta, the increase in triglycerides is essential for supplying the mother's energy while sparing glucose for the fetus. So there's a preferential preference for glucose by the fetus, while this increase in LDL, all right, serves to provide adequate nutrients for the parturient. The increased LDL levels are crucial also for placenta steroidogenesis, the production of hormones by the placenta. All right, so the placenta acts as a temporary endocrine organ as it synthesizes a number of hormones, all right, that influence the ovaries, the uterus, the mammary glands, and even the fetus. And some of the hormones that are synthesized by the placenta are the ACG, progesterone, estrogen, HPL, and relacin. And ACG is one of the tests used to detect pregnancy. All right, metabolism continue. There are increased caloric and nutritional requirements during pregnancy, and it makes sense because you need to feed the baby. You need to also feed the growing body of the parturient. All right, so there's increased requirement for protein, iron, calcium, folate, and all this. The protein requirement in pregnancy actually increases from 60 grams per day to about 70 to 75 grams per day. All right, because as most of the amino acids are being transported to the developing fetus. All right, also the calcium requirement increases to 1.5 grams per day. All right, and maternal serum levels of calcium are maintained pregnancy, while fetal needs are being met by increased intestinal absorption, which starts at 12 weeks of gestation. All right, this is a table to show you some of the anatomical and physiological changes. All right, the MAC reduces by as much as 40%. Oxygen consumption increases by as high as 50%. There's reduction in airway resistance, functional residual capacity decreases by 20%, and this predisposes the woman to desaturation and palsy during general anesthesia. The minute volume ventilation increased by 50%, tidal volume by 40%, and the respiratory rate by 15%. All right, don't forget that I said the PaO2 increases while the PaCO2 reduces to allow for excretion of carbon dioxide by the growing fetus. All right, yes, the cardiovascular system, I decided to put it here. I call them 5 H's of the changes in cardiovascular system. Number one is the hemodilution that I mentioned before, which is due to a disproportionate increase in plasma volume relative to that of red cell mass. All right. Then there's what they call autotransfusion, all right, which results from increased cardiac output during labor. Don't forget that cardiac output increases and increases even more during labor. All right. So there's increased cardiac output during labor due to labor pain, and this leads to an increase in intravascular volume by as much as 300 to 500 ml of blood, all right, from the contracting vessels, contracting uterus to the venous system. So by the increase in cardiac output during labor, the woman transfuses herself, and this also compensates for blood loss during delivery, all right, because of the autotransfusion. There's increase in cardiac output up to 140% of baseline at term, as injection systolic hormones and adjuvants are common. Then we have the hypercoagulopathy, the increase in coagulation factors, fibrinogen, and factor 7 to 10 I mentioned before. All this leads to hypercoagulable state. And don't forget the venous status that can occur. So these patients are predisposed to thromboembolic events. But note that although all of this increase, it does not actually lead to clotting or bleeding times, increase in bleeding time abnormality. A pregnant woman has what we call hyperdynamic circulation, and this is due to increased cardiac output, primarily due to increase in stroke volume, like I mentioned before, all right, and to a lesser extent by the heart rate. There's a steady reduction in systemic vascular resistance. This is due to the effect of progesterone, and this contributes towards the hyperdynamic circulation that's observed in pregnancy. So if you are asked during orals, what are the factors that contribute to hyperdynamic circulation of pregnancy? All right, increased cardiac output, reduction in systemic vascular resistance, and these are some of the things that cause hyperdynamic circulation in pregnancy. All right, hypotension, systemic vascular resistance. All right, vascular tone is more dependent upon sympathetic control, and this is very important, and that's why your spinal-induced hypotension becomes very marked, all right, during pregnancy. In addition, autocaval compression, which tends to reduce venous return to the heart, may lead to a fall in cardiac output as much as 24% towards stem. And that's why it's important for you to always put your wedge, all right, left uterine teeth for your pregnant patient going for cesarean section, even for patients who are lying down. That's why most pregnant women will prefer to lie on the lateral side to reduce the effect of autocaval compression. Left axis deviation, invalid T-waves due to AC changes may follow cephalic displacement of the diaphragm by the growing uterus. Obviously, I mentioned this before. There's an increased risk of having higher block with epidural or spinal. This is due to venous distension engorgement, which increases approximately to about 150% during the course of gestation. All right, distension of the extradural veins heightens the risk of vascular damage when you are trying to initiate your block. All right, the increased venous volume within the rigid spinal canal reduces the volume or capacity of the extradural and intrathecal spaces for your local anesthetic solution. This also will cause an increase in spread of your injected medications. All right, pharmacological changes. The volume of distribution increases by 5 liters during pregnancy, but note that it affects more predominantly the water-soluble drugs. Okay, albumin concentration falls in pregnancy. All right, so that means that drugs that are bound to albumin, you need to reduce their doses. All right, and this makes free active portion acidic agents, while basic drugs are more bound to alpha-1 glycoprotein. Cholinesterase concentration decreases by 25%. All right, but what happens is that the increase in volume of distribution compensates for the decrease, and that's why if you're doing some general anesthesia with your rapid sequence reduction, the reduction in dose of sosartanib is not warranted, because despite the reduction in concentration of cholesterol, all right, the increase in volume of distribution compensates for the activities of your sosartanib. Okay, any question before we discuss my questions? Did you follow me? Elizabeth, the first person on my list.
Yes, Prof. Good afternoon.
Good afternoon. Did you follow?
Yes, I did.
Okay. Hey, Essie Aqua is here, the married woman.
Good. Yes, Prof.